Unit 3, Lecture 3. Potential role of spirituality in humanizing care within the hospital setting. This third video lecture presents the pyramid of care, where spiritual care lies at the top and its potential role in humanizing hospital care across different hospital settings. Particularly, the role of spirituality in the emergency units, acute units, and chronic care units is discussed. This lecture will answer the last two questions of the set of 7 intertwined questions this unit is structured around. And particularly, we are going to answer to the question, is humanization of care possible? And can spiritual care be provided in the hospital setting and how? A recent review of qualitative studies exploring families' experiences of spiritual care at the end of life in acute hospital settings found that the families experiencing end-of-life care in acute hospital settings may benefit from spiritual care. In particular, it emerged that families wanted to spend time with their loved one, especially if their condition was deteriorating, and they usually expected to speak with a healthcare professional about the care provided. Dignity is a crucial part of spiritual care. Indeed, families were confident in the care their loved ones were receiving when they saw healthcare professionals to express love towards their relatives. Moreover, personal connection is crucial for person-centered care as well. Families felt compassion from the healthcare team when the providers took the time to learn their names and treat their family members with loving care and sensitivity. It is also important for families to take space for religious and spiritual practice into the hospital. Patients requesting spiritual care tended to be older with long in-hospital stay, high level of acuity, high frequency of private religious practices, and self-described degree of religiosity. This helps to identify which patients are likely to request spiritual care, and more importantly, it highlights the population of patients who likely will not request services but would still confer benefit. Chaplain intervention were associated with improvement in perceived quality of life and spiritual well-being. In spite of this, healthcare professionals rarely attempt to explore the patient's or family's need for spiritual care, with the majority of chaplaincy consults occurring in the final days of a patient's life, potentially leading to a failure to meet patients' spiritual needs. The concept of humanization of care has been increasingly discussed in the scientific literature due to the automation of care and rationing of time and staff, often resulting in dehumanized care. This systematic review examined the concept of humanization of care according to the perspective of involved stakeholders and aimed to create a shared understanding about what delivering humanized care means and how it can be implemented. The identified key elements highlight that it is not sufficient to simply treat the disease or the symptoms, but establishing a human connection. Adequate working condition was the most discussed key elements in the organizational area. According especially to the opinion of healthcare providers, fragmentation of the work process, lack of time, intense routine at work, excessive demands on healthcare providers, excessive bureaucratic and out of professional scope activities impose significant barriers to achieving humanized care. Healthcare setting not lacking in space and with inadequate physical structure and pleasant environment were also considered to be structural aspects of humanized care. Indeed, factors such as floor and room layouts and lighting have been shown to positively influence health outcomes. According to a pyramid shaped ethical perspective, several dimensions of care with increasing complexity can be implemented, including core care, human care, and spiritual care. Core care includes the dimension of right care and the need for good, competent carers. Its aim is to restore body healing. The roles are spiritual needs vary across hospital settings. In emergency and critical care settings, spiritual care is affected by the patient's clinical instability and may confront with issues such as cardiopulmonary resuscitation and management of family members facing unexpected death or the decision about organ donation. Resuscitated patients may experience near death experiences in acute care settings, such as medicine and surgery wards, patients often face a new and sometimes unfortunate diagnosis or get used to the idea of disease progression or death. In long term care settings, people are elderly and usually suffer for multiple chronic conditions. They often spend the end of their life in a facility, are cognitively impaired, and lose the ability to make decisions for their care. Therefore, healthcare professionals should consider the context and the peculiarities of each illness to tailor spiritual care, and in particularly challenging situations, they can rely on professional help such as chaplains help.